Good afternoon, and welcome to the Maryland Women's Coalition for Healthcare Reform's webinar series, Leveraging Healthcare Reform, Cultural Competency, and Health Literacy Strategies. I am your host, Sandy Kick, Health Policy Analyst with the Coalition. Today, we are excited to present this webinar, the third in a four-part series on cultural competency and health literacy, and the importance of both in our healthcare reform implementation efforts. Today, we will present Cultural Competency, Resources for Providers to Meet Patients' Needs. First, we will hear from our speakers and then host a Q&A session before wrapping up today's webinar. Please note, we have muted all phones during our speakers' presentations, but will provide you with instructions for asking questions when we get to the Q&A portion of the webinar. Now I'd like to introduce Lenny Preston, Chair of the Coalition, who will be both moderator and speaker today. Lenny?
Thank you very much, Sandy. And on behalf of the Women's Coalition, again, I want to thank everybody for joining us. We have a really broad section of individuals participating, from private practices and hospitals to state and federal agencies to nonprofits and community-based organizations. And we hope that this will prove useful to all of you and for your colleagues who couldn't be on the webinar today. Let me say now, and I'll say it again, that the presentations and the recording will be posted over the weekend on our website, mdhealthcarereform.org, and there will also be an extensive resource list there. And just to reiterate what Sandy said, we're going to save all questions to the end. So before we get into the presentations, I want to briefly introduce the Coalition to those of you who are unfamiliar with our work. We're a statewide, nonpartisan coalition of individuals and 96 organizations that are working to ensure that all Marylanders have access to high-quality, affordable, and comprehensive health care. We work collaboratively in partnership with our members, and we focus on policy, legislation, advocacy, and action. And our mission is really healthcare for all. If we could go back a slide. So that we want to make sure that every Marylander has the health care that they need and deserve, and that it's comprehensive, affordable, accessible, high quality, coordinated, and patient-centered. And we want to create in Maryland a culture of health. And healthcare reform, the Affordable Care Act, and the state initiatives really provide an opportunity for us to improve the population health overall and to advance health equity through the reduction of health disparities, to reduce costs of health care, and to improve the patient experience of care in both quality and satisfaction, and that's a highlight of what we're going to be talking about today. And I also want to reiterate the importance of creating health literate consumers. Providers really have a key role in that. So if we could go to the webinar series, just to give you a little background of what we've done up to now. In the spring, the first of this series was really the big picture. So we looked at what are the terms, what does cultural competency and health literacy really mean, how do they interplay with healthcare reform and with the federal and state initiatives. In the second webinar held early in the summer, there we really looked at how cultural competency and health literacy play into the programs, the consumer assistance programs that we have in place, and particularly through the Exchanges Connector program. So for today's objectives, we really want to focus on a brief overview of what's happened in Maryland. We could do several webinars on that, and talk about the opportunities that we have to integrate cultural competency strategies into models of care, and particularly what that means for providers, and not just for the provider themselves, but of course for everybody that works with them, because whoever touches the consumer has a role here. And then look at Maryland steps in implementing cultural competency requirements, and then end with what the patient experience really is here. So we get a hands-on look at this. And again, we'll do the question and answers at the end. So we're very fortunate today to have two terrific people to discuss this. Cherie Wilson with the Johns Hopkins Bloomberg School of Public Health, and I'll give you a little more information about her in a moment, and also Dr. Michelle Gordine, who's been a great partner with the Coalition. and they'll cover all the areas that I talked about. Their full bios will be up on the website, so we're not going to give you all of that now. And now let me just briefly touch on why providers are so important. You know this, but they really are the single most trusted messenger on healthcare and on healthcare reform. So roles in talking about with consumers the benefits of having health insurance so that we can get people enrolled and get them the card that they need and then the care that they need. The second area is really that they have an opportunity to talk about the affordable insurance that's now available at Maryland Health Connection, whether it's with Medicaid, which covers individuals up to 138% of federal poverty, about $15,000 for an individual, and then the opportunity to purchase qualified health plans with advanced premium tax credits at 139 to 400% of federal poverty, which takes a family of four up to over $90,000. And then the third piece of this, really the health literacy piece, is an opportunity to tell people how to use health insurance, the importance of annual checkups and preventive care, immunizations and screenings. Many of these individuals have never had insurance before. We all know that. We know they've been going to emergency rooms for their care. So here we have a unique opportunity to take advantage of this and create health literate consumers. Let's just look briefly at what Maryland looks like. We have about 13% of the population is uninsured. We know that the higher percentages are with racial and ethnic minorities. Higher percentage of males than females are uninsured. And then by federal poverty, about 45% of them are going to be eligible for Medicaid. And then another 44% or so are going to be eligible for those advanced premium tax credits, and then another 11% are over 400% of federal poverty and aren't eligible for those. So if we can go to the next slide. This is just gives a regional picture of what the uninsured look like. And again, remember, all of these slides are going to be up on our website over the weekend. And then just very briefly, I want to just mention a particular focus of the coalitions, which is, before I get to that, let me just very briefly, I'm sorry, we can go back to the Maryland photograph of the governor who, the day after President Obama signed the Affordable Care Act on March 23, 2010, the governor set up an executive order and a health care reform coordinating council, which immediately started to plan the rollout of health care reform implementation in Maryland with an Office of Health Care Reform, 3 major pieces of legislation, and the Exchange Board was set up by law in April of 2011. So Maryland's taken a very proactive approach, as you know if you've been reading the newspaper, and we were really in the lead until, I like to say, September 30th at midnight. It would be disingenuous to say that everything has gone smoothly. It obviously hasn't. There have been changes in the leadership at the Exchange, and they are moving forward as rapidly as they can, and I think they need all of the help they can get in order to make sure that Maryland continues to get this right. So we can go to the next slide. So the projections for enrollment, if all stars are aligned, I like to say, is in the qualified health plans. 2014 would be 147,000. The enrollment as of last week in those qualified health plans, we were only at 3,758. So the challenges are huge. Medicaid numbers look better. The projection was 108,000. And because Maryland had put in place the primary adult care program, those PAC enrollees will be automatically enrolled in Medicaid effective January 1st, 2014. So those numbers are considerably larger than what we're seeing in the qualified health plans at the moment. Maryland, to reach out to consumers to let them know, has had a marketing campaign, and then also set up an extensive eligibility outreach and enrollment program a number of pieces of that. One is the Connector program. There are 6 regional connector entities around the state that run the navigators who can take people literally from soup to nuts, from determining their eligibility all the way through plan selection, to 170 assisters who can take people all the way up to the point of plan selection. There's also a call center. There are actually over 2,000 insurance brokers and producers who've been trained to use Maryland Health Connection. And then there's a category called Certified Application Counselors. These are individuals who've been doing this work, many of them for many years, in federal qualified health centers and hospitals. And so that will bring a new contingent of outreach people in. And then also caseworkers at DHMH and social service departments and local health departments. About 1,200 of those are trained to help people with Maryland Health Connection. So a particular focus for the coalition has been to make sure that the most vulnerable get information about the exchange, about their options, and about how to select a plan. We're looking particularly at behavioral health and the LGBT population, those living with HIV/AIDS, families with mixed eligibility status. We have to remember, too, that the Affordable Care Act did not include the undocumented immigrants as being eligible for these programs. And then, of course, those coming in from incarceration. And one of the great things that Maryland has done is to say that if young adults can stay on their parents' plans to the age of 26, then Maryland, basically the parent of former foster youth, should do the same. So those who have aged out of the foster system up till the age of 26 can go on Medicaid. And those are individuals who are hard to find if they've aged out of the system. So you as providers may well be aware of individuals and need to be sure that they know about this. Another cohort that we're concerned about are women who go into the exchange with a federal poverty level between 139 and 250%, and they then become pregnant. At that point, they must go into Medicaid, which actually has some richer benefits with dental care. But there are challenges to that. They have to know that they are going to do this. They have to self-identify, and they're going to be in Medicaid until 60 days postpartum. And then, unless there's been some great change in their income, they're going to go back into a qualified health plan. So those of you who work with women in this age group need to be aware of this. And the coalition is putting out some printed materials to help connector entities and others. And among the information that we're giving on those materials is to make sure that individuals, as they select a plan, don't just look at the price of the premium or even just look to make sure their provider is in network, but they really understand what the full costs are with cost sharing and deductibles. And then to be sure that not only do they check that their provider, if they want to keep them, and I'm sure you hope they do, is in network, but also that they understand that their medications, if they have specific ones, are covered, that any preventive screenings and services and therapies are all part of their plan. And that's the kind of information that you can help your clients, your patients with as well. So there are tremendous opportunities to leverage cultural competency and health literacy with things that are going on in Maryland. And we just finally, before we get into our speakers, I just wanted to mention a few of these. There was a law passed in 2012, the Cultural Competency and Health Literacy Education Law, that you should be aware of. Maryland Health Connection has cultural competency standards. Maryland has put in a state innovation model proposal for a community integrated medical home. The Medicare waiver also has leveraging for cultural competency, as do our health enterprise zones and the state health improvement process. So there's a lot going on in Maryland around these issues of cultural competency and health literacy. So now I want to turn it over to our experts. And the first speaker will be Cherie Wilson. And remember, we're going to take questions at the end of all of this. Cherie is a faculty research associate in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, the Hopkins Center for Health Disparity Solutions, and program director for the Cultural Quality Collaborative and the Clearview Organizational Assessment. So you can see why we're so grateful that she found time to speak with us today. She'll give an overview of cultural competence in patient settings and level set us by starting with a definition of an impact on health outcomes, quality of care, and patient satisfaction. And she'll look at some Maryland-specific issues. So I'm going to turn it over to Cherie now.
Great. Thank you, Lenny. And I'm very pleased to participate in today's webinar. And the first part of my presentation is going to be cultural competence and overview for providers. So in this presentation, I will describe cultural competence in patient settings, define the impact on health outcomes, quality of care, and patient satisfaction, discuss the evidence base of cultural competency principles, and then I'll identify the need and how to measure for improvement in cultural competency. So we're going to start with a video clip to set things up. This is a video clip on Where Are You From?
Hi there.
Hi.
Nice day, huh?
Yeah, finally, right?
Where are you from? Your English is perfect.
San Diego. We speak English there.
Oh, no. Where are you from?
Well, I was born in Orange County, but I never actually lived there.
I mean before that.
Before I was born.
Yeah, like, well, where are your people from?
Well, my great-grandma was from Seoul.
Korean. I knew it. I was like, she's either Japanese or Korean, but I was leaning more towards Korean.
Amazing.
Shasina. There's a really good teriyaki barbecue place near my apartment. So I actually really like kimchi.
Cool. What about you? Where are you from?
San Francisco.
But where are you from?
No, I'm just American.
Really? You're Native American?
No, just regular American. Oh, well, I guess my grandparents are from England.
Oh, well. Hello, Governor! What's all this then? Dropping the ball into you? Let's go, Sporties! Double, toil and trouble! Mind the gap! Beware Jack the Ripper! Bloody hell! Hip hip! Cheerio! I think your people's fish and chips are amazing.
You're weird.
Really? I'm weird? Must be a Korean thing.
Thank you, Sandy, for queuing that up and showing that. So the purpose in showing that video clip is that the importance of actually asking our patients about their backgrounds and our consumers rather than making assumptions. So this really dovetails into what is culture. Now, I go out and I frequently do cultural competency trainings, and what I hear from the naysayers typically is, well, I have to learn about those other people. So from my perspective, cultural competency begins from within and the recognition that we all belong to multiple cultures. So we define culture here as an integrated pattern of human behavior, and it includes but is not just limited to one's racial, ethnic, religious, social, disability, or political group. And oftentimes these things are transmitted to subsequent generations, and it's changing and it's dynamic in nature. So what I really like about the things that are listed here are that we oftentimes don't take them into consideration. So one I like to focus upon is courtesies. Think of the last time that you had to greet someone in a social setting. Did you just shake that person's hand? If you were somewhere else, did you have to kiss the person on the cheek? And which cheek do you kiss? Is it the right cheek? Is it the left cheek? Is it 2 kisses? Is it 3 kisses? What if you're a male and you're encountering a Muslim woman? Are you able to touch her at all? And which hand do you even shake with? So, I mean, that's something that's extremely important to our culture and how we then would interact with our patients when you're greeting them for the first time. There are other things such as time orientation. So I often hear people saying, oh, my patients are so non-compliant, they miss appointments, they don't show up on time. Well, what if we are scheduling appointments during the high holy days or during a month of fasting where it's very difficult for the patient to actually attend an appointment during that time? And a UK study actually did a quality improvement project where they realized that their no-show rate for their Asian population was more than double that of their white British patients. So what they did is they actually handed out a schedule of the Muslim holidays and other holy days to their schedulers, and they not only reduced the no-show rate in the Asian patient population, but also in their white British population as well. So again, these are all things that impact our cultures. And we all belong to multiple cultures, so it's not just your race or ethnicity. And that's why I really like this iceberg analogy of culture, because we tend to focus upon those things above the surface or those things that you can see on the outside. So is someone able-bodied? That's only getting to physical disability, not mental disability. We focus upon race or ethnicity, although we can be wrong because we tend to try to put people in boxes. Gender, although these days you may not necessarily know that, and we make assumptions, and one's age. But what tends to bind us and the commonalities between us are those things below the surface. And these are the things we cannot readily see. These are these things where in casual conversation you find out that someone went to the same university you did or is from the same small town or the same state or knows a neighbor or lives in your town. And so it's these things that by asking and by interacting with other people we realize are the commonalities that bind all of us. And these are the kinds of things that we do need to find out about our patients. So what do we even mean by cultural competence? Well, first, what cultural competence is not, it is not something where you go to a new employee HR orientation training and there are 3 slides on diversity and inclusion and check, now I'm culturally competent and we've met the organizational requirement for cultural competency. It's actually a developmental process that basically extends over a period of time. In fact, I like to call it a lifelong learning. But it doesn't just affect individuals, but it also affects organizations as well as systems. And it has to do with our awareness, our knowledge and skills, and there's a whole continuum on which you can belong. So on this continuum, we can start with cultural destructiveness. So this is where you see difference, but you want to stomp it out. Difference is bad. This is adversely affecting our country or our hospital. Why are we getting these new patients who can't speak English? So cultural incapacity is where you see the difference and you make it wrong. So that's that comment I made, well, you know, my ancestors learned English when they came here. Why can't these new patients just learn English? Cultural blindness, these are the people who are well-meaning and they will say, well, I'm colorblind. I don't see color. Well, the problem with that is that even young children see color. The difference, though, is that they do not ascribe negative properties or characteristics to color. Cultural precompetence is where you see the difference, but you really don't respond adequately. So I'll give you an example. This is where you're in the staff room and someone makes an off-color joke about some particular group. It could be someone who's LGBT, a racial joke about someone's able-bodied status. And you sit there and you realize that probably wasn't the right thing to say, but you don't know how to react. So you don't say anything in fear of perhaps people thinking you belong to that group, and so you too might be ostracized. Cultural competence, though, is where you see the difference and you understand the difference that difference makes. And now you're on your way to learning how to respond appropriately. And then lastly, our ultimate goal is cultural proficiency, where now you do see differences, you realize that basically it's a positive contribution and how can you act appropriately. The thing is, though, is that as we mentioned on the previous slides, culture is dynamic. So depending upon which culture you're interacting with, you can be anywhere along this continuum. And although I do this job 24/7, I am constantly learning about different cultures. And so things that we would include in culture, and I'm going to talk about the class standards in a few slides, is it's not just race and ethnicity, although those are extremely important. And Lenny talked about those who are more likely to be uninsured are racial and ethnic minorities. But it includes one's religion or able-bodiedness status, or basically religion, and a whole host of issues. And so basically, depending on which group you're interacting with, again, you can fall anywhere along this continuum. But there is such a thing as organizational cultural competence. And here, this is where organizations have to have values and principles. So you will oftentimes see in an organization's mission statement or their values, they will put in there a respect for diversity and inclusion and treating all patients equally. But this then needs to extend beyond just the policies in the paper to the behaviors and attitudes. And if you have policies, do you actually have the structures and the supports in place to enable your staff to work effectively? So what happens is that an organization not only must simply put diversity and inclusion as a value, but they actually need to act upon it. One thing I'm talking about today is conducting self-assessment. So as a quality improvement and patient safety professional, basically what we've talked about is that what is measured is done. So if you don't measure how well you're doing in the area of cultural competency, it may look as everything is all good on the surface. We have to figure out, though, how do we manage the dynamics of difference? And it's not just with your patients, but we also have every interaction as being cross-cultural. So this affects your staff, this affects your senior leadership, as well as your board. So, for example, on the surface, many organizations look very diverse. But from a workforce diversity perspective, when they start looking at do we actually reflect our service area at all levels of our organization, they may find that certain groups are concentrated at the bottom in say, general services type positions, so housekeeping, transport, nutrition staff, security. But those people are not also represented among the clinical staff, the senior leadership, or even board representation. So what we need to do is learn about our service area, learn about the different cultures, and by adapting to these various changes that we see in our communities. And so then we need to incorporate all the items I mentioned on the previous slide into our policy making, into our administration, into practice and service delivery, and then most importantly, and with the focus of I know this organization here is involving consumers, our key stakeholders, and communities, because we cannot implement policies in a vacuum without community input. So let's talk a little bit about changing U.S. and state demographics and why this is so important. So what we've seen is that in the latter half of the 20th century, the percentage of non-Hispanic whites in the United States has decreased precipitously. So in 1950, the non-Hispanic white population was a little under 90%, and by the year 2000, it was a little under 70%. The U.S. Census Bureau, though, is projecting that sometime between 2042 and 2050, our nation will become a country that is minority-majority, meaning if you add up all of today's minorities, they will outnumber non-Hispanic whites. Now, we are already seeing this because in 2011, the majority of the births actually were to racial and ethnic minorities as well as multiracial children. And we already have 4 states, plus the District of Columbia, that are already minority-majority. And I included Maryland here, and although this data is a little bit dated, we are already at 45%. So we're already along that trajectory. And so what does this mean for the U.S. and Maryland? So, and I originally had some data for Baltimore City, but since we're talking about all of Maryland, I did remove that. But we have about 13% of U.S. residents are foreign-born. Here in Maryland, it's a little higher than that, about 13.2%. We have an increasing number of people who speak a language other than English at home. And we also have increasing numbers who speak English less than very well, and that's the legal definition of limited English proficient, or LEP. And our LEP population has increased 80% over the last 20 years. But what's extremely interesting is that the 10 states that experienced the greatest growth in their LEP populations are listed here, but they are some of our states that are the least diverse and the most unlikely to be able to deal with these changes. So, for example, North Carolina is a refugee-receiving state. And yes, North Carolina does have some metropolitan areas. You have Charlotte, you have the Research Triangle, Duke, UNC, Chapel Hill, but the rest of the state is largely agrarian or agricultural. The same applies to some of the other states here. So this is creating some major challenges for the healthcare system because they're having difficulties adapting to these changes and providing services. And then, not surprisingly, we have 8 states where at least 10% of their overall population is already LEP. And this includes the 4 states that I mentioned previously that are currently minority-majority states. So when I hear people say that English should be the official language of the U.S., I always want to show them this map, and this is changing on a daily basis. So we currently have 322 different languages spoken in the United States. So here in Maryland, we have 117 different languages spoken. And even in some of those states that are really, we think of as not being diverse at all, I'll pick on Idaho. Idaho has 82 different languages that are spoken, and even Maine has 74 different languages. So again, this creates challenges for our healthcare providers. So now let me move into a brief discussion about some federal and state legislation, mandates, and regulatory standards. So I don't know about you, but this is how I feel on an almost daily basis, trying to keep up with all the changes and how to adapt to these changes. So I'll start with Title VI of the Civil Rights Act of 1964. And this states that if a healthcare organization receives any federal funds, so Medicare or Medicaid, it must provide interpreters at no cost 24/7 to LEP patients. And if not, this is considered discrimination based upon one's national origin. I mentioned briefly at the beginning of the presentation the CLAS standards, which stands for the Culturally and Linguistically Appropriate Services Standards. These are out of the Department of Health and Human Services, Office of Minority Health. The original standards were issued in 2001. There were 14 standards broken into 3 different categories, encompassing things such as workforce diversity, language access, and those language access standards then and still mirror Title VI, as well as what kind of organizational supports are in place so that we can actually put this into practice. Now, the enhanced standards were released in April of this year, and Dr. Levis, our center director, actually sat on that panel to create these. So there are now 15 standards. They did keep the language section, but they now call it communication and language assistance. And one thing that is new is that they focus largely upon continuous quality improvement as well as accountability. And they are much broader in scope than the original CLAS standards were. They take a much broader view of diversity. So as I mentioned previously, it's not just race, ethnicity, and language, but it's one's LGBT status, disability status. It encompasses health literacy, religion. The National Quality Forum, which is basically vets a lot of the different measures in the quality world, in 2009 came out with a report about how to frame and how to measure and report cultural competency. So these were 45 different practices, best practices, divided up into 7 domains. Now, many of you are currently rolling out your electronic health records. This came out of the American Recovery and Reinvestment Act. And this is important to us because in the collection of patient demographic data, it includes the collection of race, ethnicity, and language data. So in stage 1, you had to have that data for at least 50% of your patients, and then in stage 2, it was for at least 80% of your patients. The stage 3 standards have not yet come out, but the draft standards basically had stated that they wanted to retire those standards. So I happen to sit on a different committee, the Commission to End Healthcare Disparities, out of the AMA, the NMA, and HMA, so that's the American Medical Association, National Medical Association, and National Hispanic Medical Association. We're a group with 70 other organizations, and we submitted comments asking them not to retire those standards because although healthcare providers and hospitals are actually filling in this data, there are no quality standards associated with this data. So I can tell you from a personal standpoint, I happen to be a black woman, but the majority of healthcare institutions I go to mistakenly list me as white. Think back to the video I showed you at the beginning. The gentleman thought the woman was either Japanese or Korean. It's nice that he thought she was Japanese or Korean, but for our data collection purposes, we really need to ask the patient or consumer, how does that person actually self-identify? Because we can't begin to identify health disparities if we do not have accurate data. So from a health plan perspective or a payer perspective, the NCQA came out with their multicultural healthcare standards, and it's a separate distinction program in July 2010. Great standards, and in fact, I think they're actually more prescriptive and probably even stronger than the CLAS standards. The only problem, though, is that it is an optional program. It's a standalone program. So it's not incorporated into the health plan program, and it's also not incorporated into their patient-centered medical home recognition program. And one proposal would be for them to do so. If you're working in a hospital setting, you'll be particularly interested in the Joint Commission's Effective Communication, cultural competence, and patient and family-centered care standards. A lot of their standards have to do with things that are listed in the class standards, so language access, health literacy, meeting someone's communication needs if they're deaf or hard of hearing or visually impaired, or even someone who's intubated and unable to speak for him or herself. It also talks about interpreters, bilingual staff, assessing their competency, and workforce diversity. From a patient experience perspective, we have the HCAHPS, or the Hospital Consumer Assessment of Healthcare Providers and Systems. And this is part of the reimbursement that hospitals receive, and I'll talk about that a little bit later when I talk about the business case. But there are also a cultural competency and health literacy item set that is available from AHRQ, but those are optional. And then lastly, we have the Patient Protection and Affordable Care Act of 2010, or the ACA, and this is largely what Lenny was talking about. We're currently in the period of enrollment, but I wanted to tell you about some of the cultural competency aspects of that. So I already mentioned the issue of data collection and reporting by race, ethnicity, and language. There are sections dealing with workforce diversity, of course, cultural competence education, as well as organizational supports. Health disparities research. So in this case, what used to be the National Center for Minority Health and Health Disparities was elevated to a National Institute at NIH. We also have increasing health disparities initiatives and prevention, and then also currently with the rollout of the ACA on how we can address disparities in that area as well. Let's talk about the business case. So our center was commissioned in 2009 to do a report for the Joint Center for Political and Economic Studies called The Economic Burden of Health Inequalities in the United States. So looking at MEPS data between 2003 and 2006, the researchers calculated the direct medical care costs of health disparities. And this is when you actually interact with the healthcare system and you don't receive the care that you're supposed to, and this is specifically racial and ethnic minorities. They then calculated the indirect costs of disability and illness. And what this means is things such as reduced worker productivity, not just for the worker, but for the caretakers for the worker. Those people need to take time off from work, time away from the workplace, and some people actually end up dropping out of the workplace because of disability and illness. And then there's the cost of premature deaths. In the United States, the current life expectancy is somewhere between 77 and 78, and when people are dying prematurely, again, this is impacting our society as a whole. So when they added all of these costs up, in total, it came to $1.24 trillion in 2008 inflation-adjusted dollars. On an annual basis, though, this comes out to $393.5 billion, which is equivalent to the gross domestic product of India, which is the 12th largest economy in the world. So, yes, we are making some strides in the area of health disparities, but because we haven't made as many strides as we need to, it is really costing our society. So the influence then on healthcare providers, I just mentioned HCAHPS. So when you have poor patient experience scores, patient experience currently accounts for 30% of the performance measures, while quality accounts for 70% of performance measures. So if you have poor scores, this is going to reduce your reimbursement. Also, avoidable readmissions oftentimes occur due to the lack of culturally competent and health literate care. So, for example, if you don't know your patient's health beliefs, if you don't know what kind of supports a patient has at home, if you give an LEP patient discharge instructions only in English and that person doesn't understand the discharge instructions or the medication instructions, that person's likely to end up back in your hospital. As a result, you would not be reimbursed for that. And then other issues include you have an increased length of the medical encounter, which means you have more patients sitting in the waiting room. You see fewer patients. This impacts your throughput. And then you have to devote more time to ancillary services. So what many hospitals are turning to now to try to reduce their avoidable readmissions is that they are incorporating more case managers, social workers, even pharmacists. So really to try to figure out how can we reach patients where they are. But then also, too, then providers are spending more time with activities that are not reimbursable. You're not reimbursed for those phone calls and the emails that you make to follow up with your patients. As a result, though, there is an increased risk of litigation, which means overall your costs are increasing, but then your profitability may be reduced. So there's a huge need for measurement in this area. And so I wanted to just focus upon some of the resources that are out there to help you start looking at how to measure and how you can compare yourself for benchmarking purposes. So I'll start with the National Healthcare Quality and National Healthcare Disparities Reports. So these come out on an annual basis. They are required by Congress. And what's interesting about these is that they have been out for 10 years. Actually, the National Healthcare Quality Report has been out for 10 years. The National Healthcare Disparities Reports came out a little bit later. And what it's showing us, though, is that although we're making strides in quality, we are not making as many strides as we need to be to reduce healthcare disparities. In fact, in many areas, healthcare disparities are getting much worse. So I would highly suggest that people look at these two reports. They're available on the AHRQ website at the website listed below. Also, though, what I like is they have state snapshots. So since we're talking about Maryland, I went to the state snapshot for Maryland. And we previously had been ranked average, but we've actually slipped a little bit, and we're actually now in the weak category. When you click further, you then can look at disparities in a variety of healthcare settings. So in hospital care, ambulatory care, the ambulatory care sensitive hospitalizations. So again, if you're looking at avoidable readmissions, that might be a place to start, as well as home health care and nursing home care. And then if you click on the link to any one of these sections, you then can pull up the disparities for that particular area. So what I provided here was an example on hospital care. And so because the numbers were small for Hispanics and Asian and Pacific Islanders compared to the white non-Hispanic population, what we see is that black non-Hispanic patients rank a little bit, are in the average category. And then what happens is as you look further, you can look at a variety of measures such as hospital mortality, as well as safety and some data regarding birth and obstetrics, and then you can drill down further. But this is an area in which you might want to look at your own data and compare. We also have additional state health disparities data that I wanted to point out. So I really wanted to point you in the direction of the Maryland Office of Minority Health and Health Disparities. They have a section on their website called Maryland Health Equity Data, and they have a series of reports, annual reports as well. What I like about this data, though, is that if you look at the little blue buttons here, for the years 2009 through 2013, if you click on any of these buttons, you can drill down further, and they do break it out by our racial and ethnic groups in the state of Maryland, and you can look at it specifically by a particular health disparity, by a jurisdiction, typically mean and county, as well as by a particular year or report name. In addition to this, I wanted to make sure you were aware of the Maryland State Health Improvement Process, or SHIP data. There are the overall measures. There are currently 39 SHIP objectives, but then they also track this based upon disparities, and there is county-level data as well. So in the disparity section, if you click on that, you can click on a particular county or a region, and you will see how did that county do for the white population versus the other racial and ethnic groups in that particular county. And if you're working in a hospital or even in a private practice, you might want to consider drafting equity reports. So for example, Mass General, their Disparity Solutions Center run by Dr. Joe Betancourt, came up with a series of equity reports, and what they now have is a dashboard that they display publicly on their quality and patient safety site. And this is just a sample of their dashboards. They're looking at some of the major hospital core measures that are reported to CMS, and it shows you how does the non-white population compare to the white population, and then where there are disparities. And then if there is a disparity, if you click on the button, it tells you what particular quality improvement project they put into place for that area. So then I'm briefly going to talk about addressing cultural competency needs in Maryland, some best practices, tools, and resources for providers. So here I'm going to talk a little bit about state agency or system level and organizational level initiatives. Some training tools that are available for providers. Could you go back one slide, please? Sorry, thank you. Organizational trainings and assessments that are available, and I really did want to highlight the new primer on cultural competency and health literacy. Thank you. So from a national perspective, we have 2 reports and 2 plans to address and reduce health disparities. So from the Department of HHS, we have this action plan to reduce racial and ethnic health disparities. And we also have from the Office of Minority Health the National Stakeholder Strategy for Achieving Health Equity. And what we found in both reports is that the aims are to focus upon 5 different areas: awareness, leadership, health system and life experience, cultural and linguistic competency, as well as data, research, and evaluation. So when we look at some Maryland initiatives, we have the Maryland Senate Bill 234 that was passed in 2012, which is the Maryland Health Improvement and Disparities Reduction Act. And the majority of the work to implement that has been done in the Office of Minority Health and Health Disparities in the Department of Health and Mental Hygiene, run by Dr. Carlicia Hussein and her staff. So the Maryland Health Disparities Collaborative have work groups that are set up, 5 different work groups which mirror the National Partnership for Action Strategy, or the 2 reports I mentioned previously. And they've done a lot of the work to implement Senate Bill 234. And the primer that I'm going to talk about was also developed out of that, and that was in response to House Bill 679, which passed the Cultural Competency and Health Literacy Education Act. Also, there are some other state initiatives dealing with cultural competency. So the Maryland Health Quality and Cost Council, or the MHQCC, developed or created a cultural and linguistic competency work group, and they have also implemented some of the aspects of Senate Bill 234, as well as what I mentioned, House Bill 679 on the education piece. The Health Services Cost Review Commission, or HSCRC, last December, updated the standards for collecting race, ethnicity, and language data in hospitals to be more in line with what needs to be collected for meaningful use. And in addition to that, they've partnered with several entities, the Institute for Patient and Family-Centered Care, as well as the center run by Dr. Marcos Pesquera. It used to be the Adventist Healthcare Disparity Center. They just changed their name last week. I wanted to congratulate them on that, to the Center for Health Equity and Wellness. And so they conducted regional trainings around the states. And what was interesting, I had the opportunity to attend the one in Frederick, and you were actually in the room with registrars and the schedulers, and you got to get their perspectives on some issues they had on collecting this data. In addition, from a payer perspective, back one slide, please, Sandy. From a payer perspective, we have the Maryland Healthcare Commission, or the MHCC. There is a medical care database work group for reporting utilization by race, ethnicity, and language. And those standards are going to be released any day for payers on how they are supposed to collect that data as well. So some training tools for providers. And I also will want to refer you to the primer because it does an excellent job of providing a repository of these. But one that I want to make sure people are aware of is the Think Cultural Health online modules. And they have modules for physicians, culturally competent nursing care, disaster preparedness and crisis response, as well as an oral health e-learning initiative. And for many of these online modules, there are CMEs and CEs available, so that's also an incentive to use these. And I do know that in the state of New Jersey, their physicians are required to undergo 6 CMEs or receive 6 CMEs for relicensure, and that this is the online module that they use for that purpose. As far as organizational assessments are concerned, I did mention previously the CAPS patient experience and suggesting that people start looking at the cultural competency and health literacy item sets. And there is also a great repository of various cultural assessment tools that Dr. Josepha Campana-Bacotes put out, and I listed the URL here. There are also some other sites, the Georgetown Center for Cultural Competency and the American Association of Medical Colleges. They also have some resources as well, and so I'll make sure I include that in the resource list that will be provided. In addition, from a hospital perspective, there are some other web-based and paper-based tools that are available. So as Lenny mentioned, I'm the director of the Clearview Organizational Assessments 360, and we have tools for hospitals, patient-centered medical homes, as well as the behavioral health and social services settings. The American Medical Association Ethical Force Program has a tool called the Communication Climate Assessment Toolkit, or CCATS. And then there's another assessment tool that is called the Cultural Competency Assessment Tool for Hospitals. So getting to the primer on cultural competency and health literacy, I wanted to thank the authors who were involved in this. So the authors of the primer are Dr. Olivia Carter-Pokris and Dr. Bonnie Braun, who are from the University of Maryland, as well as Dr. Carlicia Hussein and Monica McCann, who are from the DHMH Office of Minority Health and Health Disparities. And they also solicited the feedback of over 200 other contributors on what should be in here and rating this tool. So this primer is available for download. It is meant to both teach students in the health profession as well as provide continuing education of practicing professionals. So there are different modules in this primer, and it is meant to be a very helpful tool for healthcare providers as well as health profession students. In addition to that, on the Office of Minority Health and Health Disparities website, there is a Maryland Cultural Competency Technical Assistance Resource Kit. So this will give you information on if you need additional training or you need consulting services on people who are experts and consultants in health literacy, language services, as well as workforce diversity. And so I would like to end my presentation today with a public service announcement from the Texas Association of Healthcare Interpreters and Translators, or TAHIT.
I'm so sorry.
Ian Son.
She's been crying nonstop. She has a temperature of 105. I don't know what to do.
Di parolas lesan.
No, please. Every time I see her, she throws up.
Di parolas
I don't understand what
lesan.
you're saying. What are you saying? Can you just look at her? No, she's burning up. She's
Di parolas la anglan.
what?
Povos ma brandan bezodjena.
She's burning up. Feel her head.
Tongpili kanente. The Monday is Askan.
What is he doing?
Do you have?
My baby, she's got a temperature of 105. Every time I feed her, she throws up. Please, can you?
Neskila por temporais.
She's burning up. Feel her head.
Moravidig.
Please, just feel her
Emna
head.
povos kumpania.
Feel her head. Just don't let me anything about it. I don't think anyone understand what I'm saying. Please, someone help me.
8% of U.S. citizens speak limited English. For these 25 million Americans, professional interpreters can mean the difference between life and death.
Thank you, Sandy. So the reason why I chose to end my presentation with that public service announcement is regardless of whether we are dealing with patients who are limited English proficient or patients who have a low level of health literacy, which could be any patient, in fact, even us when we're the ones who are in the bed, because it's difficult to advocate for yourself, even if you work in healthcare, we need to remember and put ourselves in the shoes of our patients and make sure that we provide information in language that is understandable to all of our patients. And I think that this will really dovetail with what our next presenter, Dr. Michelle Gourdine, is going to talk about. So that concludes my presentation. Lenny, back to you.
Thank you so much, Cherie. That was just immensely informative and packed with information. So I'm just going to remind everybody that these will be up on our website, mdhealthcarereform.org, over the weekend. Look under the events link. So now let me turn to Dr. Gourdine. Michelle's a primary care physician, health policy specialist, and an expert in preventive health and wellness, and currently is a clinical assistant professor at the University of Maryland School of Medicine and senior associate faculty at the Bloomberg School of Public Health. She's former Deputy Secretary of Health and Chief Public Health Physician for the state of Maryland, and before that, the former Health Commissioner for Baltimore County, Maryland. And in her spare time, she wrote a terrific book, Reclaiming Our Health, A Guide to African American Wellness, that was published by Yale University Press. So, Michelle, I'm going to turn it over to you.
Thank you, Lenny. And as Sherry said, I am so pleased to have the opportunity to speak to everyone today about cultural competency and resources for providers to meet patients' needs. Before we move to the first slide, I just wanted to give an overview of what we'll be talking about. First, we're going to talk about the needs of previously uninsured patients, which is going to be something that's very important as individuals continue to enroll in the ACA. Secondly, we're going to talk about how to meet those needs through providing culturally competent care. Thirdly, we're going to talk about how culturally competent providers positively impact the quality of health care, patient satisfaction, and health outcomes. And we all know that the ACA has a particular focus on improving the health of the individuals who are served. So this presentation is going to boil down and discuss a few approaches to meet the challenge of improving the health of a previously uninsured and increasingly culturally diverse patient population within the time constraints of a busy medical practice, something that I think we all agree is a challenge. Hopefully this presentation will provide you with some resources, some information, and some tips to kind of help that go more smoothly. So with that, let's go to the first slide. I think that this is no surprise to most of us who are on the phone today. The uninsured tend to receive fewer clinical services for obvious reasons, central among those being the lack of access to health care. But this also includes less preventive health care, fewer or no health screenings, and delayed detection of very serious illnesses, including cancer. Next slide. As a result, we know that the uninsured are more likely to postpone or forego needed care. Oftentimes, they're trying to make a decision between going to the doctor to take care of a health problem versus putting food on the table, clothing on their kids' backs, or paying for the rent or the mortgage in their home. So know that the uninsured are more likely to experience a health decline because of that health care that's not obtained on a regular basis, and we know that have higher mortality rates. In fact, they die at younger ages than the insured individuals do who are in the same age group. Next slide. Bottom line, the uninsured are generally less healthy. They have a delayed diagnosis of health problems, delayed treatment, and as a result, worse health outcomes. Next slide. So what are the needs of previously uninsured patients? There are a number of studies that have taken a look at this, and so we actually do have some idea of the particular needs that previously uninsured patients who are coming onto the rolls of the ACA will have. They tend to initially have more doctor's visits, and I don't think that's a surprise to anyone because of unmet health care needs. They also tend to have more hospitalizations and higher medical expenditures overall. Next slide. We know the ACA will provide coverage for a significant proportion of the uninsured. Not all uninsured will be covered, but a significant proportion of those individuals will receive coverage. But what I want to point out is that access to health care is necessary, but it's not sufficient to produce better health outcomes. Next slide. We all know about patient-centered care. We have heard about patient-centered medical homes. There is a pilot program going on in the state of Maryland. We also know that patient-centered care is a key component of providing quality care as outlined by the Institute of Medicine. To ensure the best health outcomes, patients must be empowered and engaged participants in their care. So patient-centered care is not a model where patients are passive. It is one where they are active and they are engaged in the process. In order to reach those goals of empowering and engaging our patients in their care, we have to address culture because culture affects health. Next slide. So what is culture? Cherie did a great job of going over this, so I don't need to repeat what she has said. But bottom line, in that third bullet, culture helps explain why people do what they do. Next slide. And culture actually affects health in ways that you may or may not have considered. Different cultural beliefs may influence the following: when health care is sought, expectations of the patient about care, the patient's reaction to being informed about an illness, their adherence to the provider's recommendation, and even their adoption of healthy behaviors. Next slide. Delivering culturally competent care starts with communication. It's all about communication. As Cherie noted in her presentation, we are increasingly faced with a growing cultural, racial, and ethnic diversity, not only in this country but also in this state. It is practically impossible to know everything that there is to know about every culture. And as Cherie touched upon, individuals can belong to many cultures. For example, I belong to the African American culture, the culture of women, the culture of physicians, the culture of parents, so on and so forth. You can probably identify a number of cultures to which you belong as well. It's almost impossible, and I think it's impractical to expect that providers are going to need to know every single thing that there is to know about every culture, because then we run the risk of stereotyping people and placing people in boxes in which they may or may not belong. The bottom line, in my view, the foundational concept, in my view, in terms of a provider being able to provide culturally competent care, starts with communication. And we know that provider-patient communication is positively linked to patient satisfaction, to adherence, and to health outcomes, three things that we agree are extremely important. You'll see throughout the presentation that I provided a number of references for you, and those are going to be provided for you as well in a document after this webinar. Next slide. Health literacy, which we've touched upon and which this whole webinar series is centered around, is an essential component of cross-cultural communication. So what is health literacy? It is simply the ability of an individual to obtain, understand, and use information about their health. And let me just say here that health literacy does not depend on an individual's educational status or their socioeconomic status or their race or ethnicity. Health literacy really does depend on the ability of an individual to obtain, understand, and use health information, and individuals from all walks of life often struggle with health literacy. Inadequate health literacy makes it difficult to access health care, to follow providers' instructions, and to take medication properly. So we can see how important it is to cultivate a health literate population. Next slide. Even though most adults read at an 8th grade level, 20% of the population reads at or below a 5th grade level, which is pretty surprising and causes us to need to examine our healthcare materials, our healthcare resources, and how we're communicating to people to make sure that we're doing it in the most understandable way possible. And one thing to reiterate, which also is probably not a surprise, most patients will not admit to health literacy problems. Next slide. What I want to review at this point are 6 steps to improving cross-cultural communication. This comes from a wonderful reference that was produced by the American Medical Association called Health Literacy and Patient Safety, Help Patients Understand. These are very simple but not simplistic tips to get us going on the road towards providing better and more culturally competent care through better communication with our patients. Next slide. The first step is pretty common sense. Slow down. Oftentimes, as busy providers, we've got a waiting room full of patients. We have a large number of obligations to each and every one of them. So we have a limited amount of time with the individual who's in front of us. However, what's most important is for the individual patient that we're seeing at that particular time to understand his or her diagnosis and treatment recommendations so that they can follow those and we can both achieve the goal of improved health outcomes. A couple of items to note in terms of slowing down, have a seat rather than standing over the patient. Again, this invites collaborative communication between the patient and the provider. And use a good amount of your time listening to the patient rather than speaking. Obviously, there's important information that you have to provide to the patient, but in terms of the patient's understanding and willingness to follow through with what it is that you're sharing with them, listening will provide you a lot of clues as to whether or not there needs to be further discussion. Step 2, use plain language. All of us in whatever our professions might be, and certainly in the healthcare profession, have our own set of lingo. And that language is perfectly fine to use when we're talking to our colleagues, but certainly with our patients, plain language is best because the goal is understandability, and I've given you a couple of examples on the slide. Next slide. Show or draw pictures if appropriate. That is pretty self-explanatory. Helps to improve understanding. Step 4, limit the amount of information provided. It's not important, for example, for a newly diagnosed diabetic to understand the pathophysiology behind diabetes. The most important and key information that we should focus on probably has to do with the individual's understanding of their treatment and to make sure that they understand how to administer that. Repetition is also very important, and other members of the team, in addition to the provider, can help to repeat the key information that the patient needs to understand. Next slide. Step 5, the resource guide suggests using the teach back technique, which basically attempts to help the provider discover whether the patient really understands what it is that you've shared with them. I think all of us have experienced a time where we've shared information with patients and they don't quite get it, they don't quite understand, and that's okay. The best way to find out is to ask the patient to explain what they heard you say. And if they didn't get it correct, attempt to reteach the information in a different way using a different approach. And then step 6, encourage questions. This is essential. What's often useful is to invite a family member or friend to sit with the patient during your discussion with them to help them to understand and to ask important questions that help them adhere to your recommendations. Next slide. So in summary, these are the key points that I want us to take away from this presentation. Previously uninsured individuals may be less healthy and initially require more medical services than the insured population. Because the uninsured are disproportionately members of racial and ethnic minority groups, there may be cultural barriers that can potentially affect the quality of care that's provided. Yet effective cross-cultural communication can improve health literacy, patient satisfaction, adherence, and health outcomes. Next slide. This is a quote that I think many of you are familiar with from Sir William Osler. It's much more important to know what sort of patient has a disease than what sort of a disease a patient has. Next slide. So this concludes my presentation. Lenny, I'll turn it back over to you.
Thank you so much, Michelle. That was, again, most informative. And I realized as you were going through those slides that my own provider would get about 100% on that, on your basic sort of cultural competency test. So I'm going to let her know that. So now we want to open it up to questions, and I'm going to ask our tech guru, Zenobia, to come on and explain how we're going to do that.
Thank you, Lenny. I'm now officially beginning our Q&A session. You should hear an automated voice saying Q&A session started. Great. If you'd like to ask a question, first hit *6 to unmute your phone, and then when prompted, press 1 to enter the question queue. When you're prompted, state your name, organization, and question.
Okay, so while we're waiting for Zenobia to others to queue that up, maybe I could go back and ask Cherie. Michelle ended with those 3, sort of big key messages. Cherie, I wonder if you could give us your sort of top 3 things that you want to be sure that everybody walks away with today.
Yes, thank you, Lenny. So I guess my top 3 areas would be, again, I'm a huge measurement person and a quality person. So I would like people to start with thinking about how are you collecting your race, ethnicity, and language data. Do you have training for your staff in place? Because one of the big areas I'm seeing is these electronic health record systems are rolling out. There's no training involved, and this is going to be an issue of garbage in, garbage out. So that's one of my key points. Next is if you are providing training for your staff, does it include all of your staff? Because I always get requests to train clinicians, and as Dr. Gordine was saying, extremely, extremely important, especially with this population. But we also need to train the non-clinical staff, what we would call our support staff. Because if you think back to the last time you had your own clinical encounter, how many non-clinicians did you interact with before you even saw a clinician? It could have been the parking attendant, the security guard, the receptionist, the scheduler. And if they're not interacting with you in a culturally competent manner, that reduces the patient experience, It might reduce patient trust. In fact, that patient might decide never to return to that practice or healthcare organization again. And then lastly, I would just like to implore our providers and our healthcare organizations, because we are talking about the Affordable Care Act, please educate yourselves on where to send your patients for assistance. Because one thing I'm finding in talking to various healthcare providers, they don't know who in their city is a contact person. They don't know what phone number to call. And Lenny and Sandy, I really want to thank you for conducting these webinars and all the resources that you're sharing, because a lot of what we're talking about here is cultural competency and health literacy. And as we know, a lot of the materials that are out there aren't really written in a health literate manner. The level of literacy is very high, and I'm working actually with a Spanish-speaking population, and that level of health literacy is even lower, and the materials are in an even higher level of health literacy than the English language materials. So we're struggling to figure out how to reach these communities as well. So those would be my top three. Thank you.
Great. Thanks, Cherie. And let me just pick up on the general information on the Affordable Care Act. There are other webinars available on our website, ACA 101, that others may find useful if they haven't accessed those already. So Zenobia, do we have any questions?
We don't have any questions in the queue, so if anyone has a question, they can just press *6 and jump right in the queue and get their question in.
Great. So, and for those that are on the call, if you don't have your question today, or and it comes up to mind later, if you just send it to the coalition, you can do that through the contact link on our website, or leni@mdchcr.org. We now know where to find Cherie and Michelle, and we'll get answers for you. And also, if you have colleagues that you think would find this webinar useful, we hope that when you get over the weekend or on Monday, the link to the resource page, that you would forward that on as well. So let me check again if there are any questions.
We don't have any in the queue. Nope.
Okay. So I'm going to thank everybody, and if we could go forward to the slide.
Lenny?
Yes.
Lenny, sorry to interrupt, but I just saw a question pop up here on my screen, and I didn't know if people could submit their that way, but I saw something that asked, I believe, is there an electronic app that can be used to assist clients?
So I'll turn that over to you two.
I would probably need a little bit further clarification about that. Is that an app regarding how to enroll in the ACA and the marketplaces? Is it when you're actually interacting with your patients during an encounter? Dr. Gordine, would you need that clarification as well?
Yeah, although I'm assuming that they're talking about interacting with the patient in the encounter. I am not familiar with that. Doesn't mean it doesn't exist. It just means that I'm not expert on that particular part of what we're talking about here. I think that it's a great thing to research or to explore because there are many medical apps that I am aware of that are popping up all the time. One thing I would caution people to do is to ensure that the apps that you do use to assist you in interacting with your patients, ensure the quality of those apps. But I receive information quite frequently on other types of apps that help within the clinical encounter, so I wouldn't be surprised if there were some apps that might be helpful. I just don't know about them personally.
Right, and I'd actually like to echo Dr. Gordine's caution of vetting the app before you use it, because when I do trainings on language access, I frequently have people ask, well, can't I just use Google Translate or Babelfish or just pull up my iPhone and, type something in and have it translate for the patients? And from a risk management perspective, that's really very difficult, and no, the quality of those are very poor. But there are some mobile health apps available out there, and if I'm able to pull some together, I can try to put some in the resource list. And Lenny, there's another question that came through as well.
Yes, and I didn't catch the whole thing. If somebody else did, or Sandy can get them to pull up.
Yes, because they're appearing on our screens too here. So, did you want me to read it, or?
Yeah, yes. If you've got it on yours, that's great.
So the question is the government looking to decrease literacy of health information? So,
Okay.
Dr. Gordine, I didn't know if you wanted to take that one, or I could take that one. Or...
I'm happy to take that. I actually see it now. I am going to assume that what they mean is whether or not the government is going to ensure that health information is at the appropriate health literacy level, as I discussed, around the 5th to 6th grade level. The answer is yes. There is an ongoing effort by the federal government, led by HHS, to look at the health literacy of health information as part of their entire class standards initiative that's been ongoing for some time. That also is taking place at the state and, by extension, at the local level here in Maryland as well, to ensure that all health materials are written at the appropriate level for maximum understanding.
Right. Yes, and that gets back to what you were saying about plain language, because there are the various plain language task forces across all the agencies, and there's a requirement that one writes in that manner.
Great. Thank you both. I don't see any other questions popping up there. Zenobia, were there any others?
There are none in the queue.
Great. Okay. Well, let me bring this to a close and encourage everybody to continue to stay informed and get involved. You can watch for the Coalition's alerts. We do, if you're not signed up for our email list, we are now sending a weekly alert each Monday to let people know what the enrollment numbers are, what the issues are at the exchange, what else is going on around the state. And we are happy to travel around the state to do in-person presentations for groups, as well as to develop audience-specific webinars. We did one with the Academy of Pediatrics, and we're happy to do more of those. I would also encourage you to share your stories with us, good, bad, ugly. All of them are helpful to us, first of all, in knowing what's going on the ground, and then important in helping us to understand what the issues are and where we need to address policy or other issues and where advocacy is required. So we will be posting to the website a very complete list of resources that Cherie and Michelle and Sandy Kick with the Coalition have put together, as well as the PowerPoint, which I mentioned earlier. And then also on the next slide, you'll find some links to the Maryland Health Benefit Exchange and to the public website, marylandhealthconnection.gov, and then also a link to the federal site. And there's much more information of this type up on our website. So our next webinar, and we have not yet set a date, but early in the new year, will be the ultimate goal, a culture of health, educated consumers, and small businesses. So getting us to that health literate consumer. If you have other ideas for webinars that you think we should be doing, please let us know. Send us suggestions for speakers. We'll take all of that and put it into our educational hopper. And again, I want to thank you for coming today. If you, as I say, if you think about what you've heard or go back and look at this online and new questions come up, you'll have our email addresses, so please feel free to contact us. And again, a very special thanks to both Cherie and Michelle, just really outstanding presentations filled with information. I know I learned a lot, and I'm sure everybody else did. So thank you, and thank you all for attending today, and we hope to see you soon. Goodbye.